Hello and welcome to my channel. My name is Peter Abraham. I'm a registered nurse with experience in cardiology, medical surgical, long-term care rehab, and hospice nursing. I'm also a book author who's written many books and guides for hospice nurses, holistic nurses, and hospice caregiver. If you're new to this channel, welcome. Thank you for visiting and for your time today, whether short or long. In this channel, we look at chronic diseases that turn into terminal illnesses. Holistic nurses like myself, we're not just looking at the numbers, mind, body, spirit, and soul, looking at you, the individual. Hospice nurses, of which I am one, um, and topics related to those areas, including book writing and overviews of books either that I've written or am in the process of writing. If this is something that interests you, please subscribe, like, comment below. This is a non-judgmental channel. The topic of today's video is going to be the overview of the final chapter and the conclusion and some of the appendices of the upcoming book, Hospice Clinical Pharmacology, Critical Thinking for Comfort-Centered Care. There are many books for clinical pharmacology out there. If you're any type of nurse, let alone a hospice nurse, you've probably read one to several. If you're an advanced practice nurse, you've probably gone into a very deep dive. But in my, what do you call it, market research, or just I'm a geek, I love research, there's not books out there specific for how terminal illness, the last 6 months of life, impacts pharmacology. For example, and we don't want to go down a rabbit trail on this, a lot of the pharmacologists that specialize in end-of-life pharmacology state that we should consider every patient on hospice to be at least CKD stage 3, whether they're diagnosed or not. And there's reason for patient safety. So we, as nurses, we always want to look at how do we improve patient outcomes. For hospice, we want a good death, which is typically defined by the patient. What do they consider a good death? Now, most would say they want to be comfortable by their definition of the word, not our definition. And part of our job is how do we accomplish that without hastening death, which is why I believe this book is going to be very important, without hastening death, without purposely prolonging life. Now, I know I don't know too many people would complain, at least before they start to transition, that if they live several weeks longer to several months longer, I don't know of any complaints. They do get to be very uncomfortable in the transitioning phase or the active dying phase if that's prolonged. But our job is to keep them comfortable through whatever time remains. So before I go much further, I like to encourage all my viewers, as well as a reminder to myself, what am I grateful for? So I am grateful for attending a small business in-person event. I don't know if small business is the right word, but the local area that I live in, central Kentucky, is hosting for those who are starting businesses, those who are brand new, those who maybe they just have an idea, and they're hosting an in-person event. And I am so much looking forward to that. This video is recorded just prior to that event. Um, but I'm looking so much forward to that event where I explore. Right now, I am a book author, but I'm currently investigating courses, both in person and via online, for my fellow holistic and hospice nurses and possibly for caregivers. So I'm looking at that. I'm also looking at I'm hopefully not going to kill the word concierge services, where as a registered nurse, there are certain services I and you fellow nurses can perform without doctors, nurses, or if we establish a relationship with the patient, we can reach out to the doctor to obtain orders or review orders to help our patients out there in the field. So there's many ways for us as nurses to be out there and away from the bedside. And for those of you who are looking for ideas on how to do that, I offer free advice in this area, so feel free to comment below. But there's Nina Hart, who has a business in this area. There's Teresa Sanderson and others who are out there to encourage others. And in their cases, they are consultants, but they've been doing this for much longer than I have. I don't consider myself a consultant at this point in time. That's why I'm saying my advice is free. You're not going to abuse my advice. If you don't take it, I don't know it all, and I don't have to be right. I just want to brainstorm and share. So without any further ado, let's dive in, and then we'll come back for the outro. Continuing with the overview of the upcoming book, Hospice Clinical Pharmacology, Critical Thinking for Comfort-Centered Care. This is an overview of the last chapter of the book, Challenging Provider Orders. So this is a sensitive topic because doesn't the doctor have the final say? Well, first off, the patient, the medical power of attorney have the final say because they could refuse medications and treatment, or they could say, I'm not going in that direction. Patient autonomy trumps everything. My ethical opinion. But as hospice nurses, we are advocates. We are advocates for our patients. And so if we have a situation, maybe it's an admission, or more often than not, we have those family members, and I do not mean this in a demeaning way. I do not mean this in a negative way, but they're similar to helicopter parents. And I still remember he's no longer with us, but the daughter of my patient with this very large abdominal aortic aneurysm, just after I left, and we had a full discussion on everything, this is rural, called their provider, got new orders that I found out my next visit. And I was seeing this patient 2 or 3 times a week. Okay, you have to deal with that. And it's like, and just as a very critical note for all of you, if you have those family members or those facility staff members, encourage them and praise them. Do not, this is hard enough for everybody. Encourage them and praise them. Love them. Shower them with love. You may have to tweak the direction that they're going, but encourage them. Always. That's always the right answer, is encouragement. So, but more often than not, you are going to see this in your facility patients where the doctor does the rounding maybe once or several times a week in between visits. And you get there, and I encourage all of you who are dealing with facility patients, once a week is perfect if you can get it in, but at least twice a week, I mean, every other week, sorry, I was going there, once every 14 days, you should be getting a med rec. Because asking I can't, I've lost track of how many times I've asked the nurses, any med changes? Nope, nothing new. And you eventually get that med list, and you're like, the date on this says XYZ, but I asked you the last time I was here any change. You said, oh, I forgot. Number one, don't go there because that's discouraging them. You're just pointing out flaws. Everybody's human. So when you can, reconcile every visit, or at least once a week, best case, or at least every other week, worst case. And for those who have unbelievably heavy caseloads, my heart goes out to you. I've been there, still remember 29 cases. If you get it in once a month, I'm not here to judge you. But those are the ones that you find out that somebody made a change. And if we believe that it's in the worst interest of the patient, it's going to make them more uncomfortable, or we're noticing things, ethically, we need to advocate. So this entire chapter, it's one of the longer chapters of the book, goes into our obligation to advocate, why it's so important, the learning objectives, How do we recognize what are the red flags? Clinical examples. Looking at prognosis. Everything that we do in hospice should be in mind with both what are the goals of care and what's the prognosis within those goals of care. Clinical examples. Let me just make sure that that's 4. I'm just trying, again, this is a draft. I'm hoping to have it published by the end of this week. We'll see. It's looking more for quality than speed. The draft of the whole book is done, including all the appendices. Clinical examples. What are your resources? Your stop frail, your Beers criteria, and even though the star criteria is generally used in Europe, I do find it to be very handy. The stop frail is more in tune because it is looking at limited life expectancy. What are your evidence-based tools? And going over those with you, again, by clinical example. If you've not seen from all the previous overviews, I hate statins. 0.8% absolute risk reduction with the side effects that do happen the longer that they're on the med. Short term, may be fine. We typically get them when they've been on it for years, and I don't want to go on a rabbit trail. But considering discontinuing if medication appropriate index, anticholinergic burdens, being very hospice specific. And the catch for statin, years to have time to benefit and years to build up toxic buildup. I'm stopping. Clinical examples. What about organ dysfunction with medication safety? This has been stressed throughout. There's a chapter on renal, a chapter on hepatic, a chapter on cardiac, but this is just drilling down in why this is so important for us to be advocates. Symptom focused versus disease modifying approaches. The symptom approach is we want to prevent symptomatic hyper or hypoglycemia. We're in a hospital setting before hospice, strict glycemic controls. So you can think of this as the before hospice and the after hospice philosophy, or I should say in hospice philosophy. Deprescribing principles, which have been talked about throughout. Clinical examples. Now here's where we get to the meat of it. There are frameworks for challenging provider orders. The most common tool that we've been taught in nursing school that almost every nurse should know inside and out by the back of their hand is that SBAR, the situation, background, assessment, recommendation. That is your front line and clinical examples. But then again, what happens when the provider, we gave her SBAR, they're not listening? Then we have, and I'm not talking about cussing in terms of foul language, but we have I have a concern. I'm uncertain about this. This is not safe. Please stop and think this through. And again, clinical examples and working through things along with the practical application. Just walking you through that example. Now the DESC model, it's a tool for very difficult conversations. This is where either you have a provider that's always been hard to deal with, and you know the S bar is going to most likely not work, and you've tried the CUSS. This deals with it from a different angle. We're going to describe the situation. You're going to express concerns. You're going to suggest alternatives. And then you're going to go over the consequences of what ifs, practical applications. How do you evaluate how you're doing in using the DESC? Then some practical strategies for uh, building rapport. So as you work with your providers, start off small. The more you build a relationship with the provider by calling them over stuff to ask them and involve them in and say, here's my SBAR, and have them buy in, the more you have the provider go, well done, your name or however they refer to you, well done, good and faithful soldier, so to speak. When you have those harder conversations, those are easier to get when you've already built trust and rapport. And a lot of this goes back to, for any of you who worked in the hospital, I still remember the times, and you've probably all been there as the brand new nurse who called the provider and you didn't have your vitals, or there was something you didn't have an answer to that you could have or should have. Uh, so always try to have your data available. And some grading, some self-assessment tools. We always want to maintain professionalism. Remember, at the end of the day, the doctor has I want to say the final say, because the patient can say no or yes, but when it comes to the orders, the doctor has the final say. So always maintain professionalism throughout. Clinical examples. When the initial approach fails, and just as a side note, you want to do your best working with the provider that you're working with, and that could be the medical director. But if you have a worst case scenario and you absolutely believe in your heart you're right, you can go to your IDT. You can go to your supervisor. You can involve another provider. Be very careful, because there is always a potential for you to unintentionally burn bridges, and that never works out well. So do it with extreme caution, and have a pathway to save face for all parties to not burn the bridge. So plan that out as best as possible. So support clinical judgment with evidence, preparation checklists, clinical examples, and then we're getting into the case studies as we head towards the end of this chapter. Interventions and rationale, terminal agitation. This can be tricky with certain types of disease processes. And by the way, I'm sure we've all had providers that are just up to dose, and sometimes that's not the answer. Sometimes it's the spreading out the dose. Sometimes it's looking to a different med. We have to be the advocates for our patients. preventing renal injury. Remember, our goal is not that we don't want to hasten death. So that's part of why for this book is give you the tools to critically think, to have comfort-centered care where we're not interfering with the timeline of life. We're supporting the timeline and keeping them as comfortable as possible. Addressing polypharmacy, and then we'll get to the conclusion. Unlike other episodes where we get done, we're done, I do want to show you, we do have the conclusion to the book itself, which is very short. We have APA-based references, glossary of terms. When labs are available, looking at this in hospital context, those of you who've read my clinical pathophysiology for hospice nurses, yes, this is an appendix from that book. Foundational opioid conversion ratios. This is a free PDF document I put out there on 2 Facebook hospice nursing groups. If you don't have access to this and you're not going to buy the book, please reach out to me and I'll see about getting you a free copy of that PDF only. Some quick reference guides, renal dosing for antibiotics and opioids when we have renal clearance, as well as how do we tell when we don't have that information. Hepatic guidelines for the liver impairment, opioid selection and renal disease. Again, this is just if you want to make a photocopy. Prognosis-based deprescribing. I like to have appendices that if you want to make photocopies, you could have that as part of your clipboard. Then what about a decision tree? I mentioned about SBAR should be your go-to. Well, how do you know when to use each? So I give you a table description, a decision-making factor, and then what does that actually look like as a decision tree? And then some examples. And then we're done for there. So I do thank you for that, for your time. Thank you for your time watching that overview. This book I'm hoping to have published this Easter weekend with Kindle and paperback and hardcover being available hopefully by that Monday following Easter weekend. If you have any questions, please comment below. As I shared before, this is a non-judgmental channel. I welcome different points of view on the topic, whether it be this book that we've been discussing. If also maybe you're looking at the field of hospice or enlisting nursing and you're saying, I would have loved if there's a book on fill in the blank, or however you want to show it for the blank. Comment below. A number of the books I have written are because my fellow hospice, holistic nurses, as well as friends that I met along the way in terms of caregivers, like Martin Lewis, who lovingly cared for his mother on hospice services, asked about why not writing a book that goes deeper into the living will than anything else out there, focusing on advanced directives, feeding tubes, artificial hydration, and so on and so forth. And or Tanya Frazier, who said too many of hospice nurses out in the field, the moment they notice oxygen saturation is dropping, let's throw on oxygen, which is not always wrong, but there's a time and place for that. So she encouraged me to write the book Breath of Life, and then I also wrote a end user, a caregiver version, Understanding Breathing at End of Life. Or Amy who cared for her father out in California, who was running into so much struggles with a hospice agency that was really on the edge of violating Amy's rights. I say on the edge because I'm not a judge, and I mentioned this is not a judgmental channel. So I wrote the book of understanding your rights under hospice. So if you have ideas and you would like to get have something written, I cannot promise you monetary income. I'm a small time writer and publisher, but I have dedicated in my books Ed Braddock for my oops, don't went to pull out the wrong hardcover that I don't actually. That's the one that I'm waiting for. But hospice, my clinical pathophysiology book is Ed Braddock, a fellow hospice nurse, uh, about pathophysiology. So ask, and I'll see what I can do. Thank you so much for your time, and God bless.